Hello, listeners, and welcome to the Heart of Healthcare podcast. I'm your host, Hallie Tecco. Most people still think of telehealth as a synchronous online visit between a patient and a provider, but the real opportunity goes far beyond that. It's really the chance to redesign care at scale for a hybrid and remote world. This is particularly important with mental health treatment, where the current care model presents systemic quality issues and is ill-equipped to support the growing demand for care. Long wait times for appointments, short time with the provider, cookie-cutter treatment, and infrequent support. This doesn't work well for people suffering from anxiety and depression. And what it's come to is that primary care doctors are writing 80% of antidepressant prescriptions. Today, I'm talking to Brad Kittredge, the founder and CEO of one of my portfolio companies, Brightside. Brightside makes it easy to get top quality depression and anxiety care from the privacy of your home. And this includes both medication and therapy tailored to the individual's needs. Brad, thanks for being here.
Really great to talk to you, Hallie.
I was trying to think about when we met. I believe you were at 23andMe.
Yeah,
and
that was a long time ago.
It was probably 2012, 2013.
Yep, I think so. Nearly 10 years
ago. Yeah. So can you tell our audience a little bit about your background and what ultimately led you to the work that you're doing now at Brightside?
Of course. Like many people, I think I got into digital health out of personal experience. I was in my late 20s and in that period of life where I think I still felt kind of young and invincible. And I was honestly really disinterested in working in healthcare because I saw the healthcare system as slow and bureaucratic and in that way kind of boring, honestly. And then I had a sort of rapid onset of some health issues where overnight I had to use the healthcare system in a much more intensive way than I had ever had to before. And I had a really hard time finding the right care. I went to some doctors and they kind of shrugged at me and sent me on my way and didn't seem to care to help find the next landing for myself or for me. And I tried to get my own data. And believe it or not, at that point, it was still just really hard to get data from a records office at a hospital.
Yeah.
And
you're like, I don't have a fax machine.
No, they just wouldn't even give it to me. They would give it on like a CD-ROM, but you had to wait weeks and if you could get it at all. And so it was just this black hole. And the reality is that I felt really scared. I felt unempowered and I felt like I couldn't do anything to help myself. And I was just sort of at the whim of whatever was happening in my body and not being able to find the right help for me. And that was just not a good feeling. I think we've all felt that kind of feeling in different parts of our lives where we're really unempowered. And so my reaction and my approach was to try to find something to do about it. And so I went online looking for tools and searching around. And at that point, really all there was were the Yahoo groups where people were sharing information and trying to help each other. And after a fair amount of searching, I found some stuff that was helpful for me. But in the process, what I felt like I really found were millions of other people like me who weren't getting what they needed out of the healthcare system. They wanted to take a more active role in their health and healthcare, but they just didn't have the tools to be able to do so. And at that point, they were largely not really considered a central stakeholder in the healthcare equation. And it was really the beginning of the empowered patient movement that I know you were a part of and a lot of the work that you did, Hallie. And so it really just catalyzed a fire for me. And I got excited about the opportunity to build tools to help people better manage their health and healthcare and put the patient at the center of the healthcare equation, make it much more consumer driven, and to try to do some innovative and impactful things. So that set me off on a mission. I knew that as someone new to healthcare who just really didn't understand the complexities of this system, that I needed to get a crash course. And so I went back to school. I did a master's of public health and an MBA together at Berkeley, and just tried to dive into the inner workings of the healthcare system and understand all the different players and incentives and structures. And since then, I've been building products to try to help people manage their health and healthcare.
Yeah, I should have done my MPH and my MBA together. I ended up doing my MPH about a decade after. And I really think they're both so valuable for really different reasons. And I think there's a lot of innovation that someone who has a better understanding of public health could kind of come in early and help steer you in the right direction and make sure that kind of the values of the company are aligned with patient impact.
That's right. Yeah, I really agree with you that if you look in a school of public health versus a school of business, you find a really different archetype of person and studies and approaches and ideas. And so being able to straddle that is actually a really valuable perspective. And so I'd encourage anybody who's interested in the business of healthcare to really consider at least some coursework, if not a degree in public health as part of that.
Yeah, absolutely. So you started off, well, I guess you worked in more traditional healthcare. You were at McKesson and then you went to Jawbone. I'd love to hear kind of the Jawbone story. You were there
Yeah.
early.
Yeah.
They were going to be a tech company, but then they turned into a health company and then eventually it didn't work out. You want to give the quick story of
Yeah.
the Jawbone story?
I imagine there are other podcasts who have gone into depth about what happened with Jawbone Up.
Yeah.
And it was a really interesting time. And yeah, my first job out of school was at McKesson. I wanted to get some exposure to traditional healthcare. And the reality is that I just did not last long there. I was not a good fit. I was just frustrated and bored. And it was that same old healthcare that I had perceived and experienced. And so I quickly started looking for a place where people were trying to think differently and approach problems and opportunities in new ways. And I had never heard of Jawbone, but it was a technology company focused on first Bluetooth headsets, and they had some noise canceling technology and some interesting headsets. And then they moved into Bluetooth speakers and did some phenomenal product design. They worked with Eve Bahar at Fuse Project and really prioritized design. And then I don't know, I wasn't there when the decision was made, but decided to make this leap into wearables. And so Fitbit was out on the market at that point, but it was a little fob that goes in your pocket. There wasn't any wearable lifestyle tracking. And Jawbone decided to launch Up and to be the first wearable lifestyle tracker and to focus a lot on the consumer experience and on sort of the science of habit formation and behavior change, really trying to focus on how people eat, sleep, and move. And I found that really interesting. How do we actually empower people to make better decisions day to day? And behavior change is arguably the hardest problem in healthcare. And I liked that it was a set of outsiders trying new and different approaches. It was fun to join and to jump into that energy. The reality that we found, though, I joined right before Up was launched. So I wasn't around with the Jawbone team in that period of formation, but jumped in and the product launched a few months later. And we quickly started to hear through our customer care that the product was having a lot of issues and it was failing. And this was my first time working in hardware and more intensively in sort of a more consumer software. And it was really complicated to ultimately diagnose and figure out what to do about it. The reality is that the product design, in my opinion, was fundamentally flawed from the start, that it was a flexible computer that you wear on your wrist and obviously a very simple computer, but flexible computers tend to break for lots of different reasons. Computer components are very fragile. And so the design was beautiful. There were a lot of great things about it, but in the end, the design was its own undoing, and that the product just couldn't withstand being on people's bodies and the movement and the moisture and all the different things people do throughout their day. And so it was a real crisis mode. Obviously, if you're building hardware, you're investing millions of dollars in the design and the fabrication and the inventory. And Jawbone had a huge opportunity. They had shelf space, waiting at Target and Best Buy and other big retailers. But when the product started failing, they just couldn't, fill the shelf space with reliable product. And it was a scramble to diagnose it and try to figure it out. And there were a few interim fixes, but ultimately that was sort of the undoing of the program. And I think probably the downfall of the company. So they were aiming high, prioritizing a lot of the right things, but it just underlined the need for meticulous and thoughtful execution at every phase. And in the end, I learned so much there. First and foremost, just really great people at Jawbone, smart people in product management was my crash course in product management. I learned a lot from my boss and manager, Travis Bogard there, but also really great user-centric design. That was something that Jawbone always did well, both on the hardware and software side. And it was my first exposure and real crash course in the world of design that impacted everything I've done since then.
Yeah, they nailed the design. I feel like it was the hot Christmas present of, I don't know, 2013. Yeah, it was on everybody's wrist. It was a status symbol of being health conscious, and it really was beautiful. It's too bad.
Yeah.
Do you think that okay, so obviously hardware is really hard, and I think it's important to note that you haven't done another hardware startup. If they had been able to get that piece right, and a lot has changed in the last decade, and miniaturization of these little computers is a lot easier now. Do you feel like the timing was also a piece of the ultimate failure?
Probably. Everything's gotten cheaper and easier and more reliable in incremental phases. And so being early and being first, you have to figure a lot of stuff out and make a bunch of things up as you go. And often companies don't get that right. And so being first can be an advantage, and it can be a disadvantage. In this case, I think it was a disadvantage. At the same time as during the period where Jawbone was still operating in the space and Fitbit was able to get a lot more iterations and product launches out. And so I think they had a different stance and a different sort of investment profile, and that they were able to iterate and learn faster than Jawbone was. And ultimately, I think that's one of the things that allowed them to be successful. They kept their design simpler. And you'll notice in every wearable today, all of the components are in a rigid sort of central unit, and all of the sort of other elements are flexible and don't have any sort of distributed components or sensors around them. And that's really been just the winning design that balances the wearability and usability with the durability and manufacturability of all of those things. And so Jawbone had a chance to win, but I think there were several things that made it so that Fitbit was better prepared to do the things that the market needed to get through that early innovation phase. And you can see the success they had because of it.
Yeah. Although I feel like now it's difficult for them to compete with the Apple Watch.
For
I mean, it's
sure.
hard to
And that's sort of
differentiate
natural market convergence there, that early in those days, of course, they pictured a Fitbit on the wrist of every American. And, I think that as they grew and saw the market saturate and start to slow, that they realized that it was a smaller market that they were potentially going after. And once they went public, that's obviously hard because there's a lot of pressure to continue growing, but there are natural limits to what that market is. And so, you see them trying to extend into smartwatches, and smartwatches overlapping with fitness trackers, and even phones overlapping with fitness trackers. That makes it difficult. And I think that's ultimately why their sort of growth opportunity as a public company was tapped out, and that Google picked them up.
Yep.
Because I think Google can see bigger uses and broader plays for the wearability and the data.
Oh, totally. And imagine Google's going to be positioning the Fitbit as the competitor to the iWatch and
That's
add
right. They
more.
didn't have their own equivalent, so now they have a platform to build off of there.
Yeah. Well, let's switch gears and talk about Brightside. So what have been kind of like the recent, you founded this company 3 years ago. Is that right?
Oh, it's been 5 now.
Oh my gosh.
Time flies.
Flies.
Yeah.
Okay. 5 years
2017.
ago. Yeah. So, I mean, and so much has changed in the mental health space in that time, but let's go back to 5 years ago when you were starting Brightside. What were kind of the culmination of events that led you to believe that you wanted to pour the next 5-10 years of your life into this company?
Yeah. Is it okay if I rewind a little bit from there? Because there were some really important experiences that led there that actually were right after Jawbone. So from Jawbone, as I went through that crash course in product management and design, I was really excited to get a call from 23andMe. And it was a company that I really admired. I had, of course, in watching the digital health space at that point, there were only a few companies that were really notable. And 23andMe, in my mind, was doing some of the coolest work of trying to make genetic testing accessible to consumers. And was excited to get a call and be able to go join the team there as they transitioned from being, in some ways, kind of a hacky genetics startup to trying to build and scale a real consumer company. And so, was really inspired by Anne, who's a phenomenal, thinker and leader, and Andy Page, who came in as president there and just a great business leader. So came in and joined the team with these ideas of how do we make genetics both accessible and understandable, but also valuable and actionable. How do we take that data and help people actually change their health and their lives? And on my third day of work there, we got a letter from the FDA. We were sitting in an exec offsite, and a FedEx package arrived, and Anne got a call that the FDA said they considered that test to be a medical device, and that 23andMe had to stop selling it and to take it through the FDA approval process. And there was all this excitement at the company the day before, and then just the wind out of our sails at that point. And in retrospect, what it was, and it's such a valuable experience for me because it was really a front row seat or participation in the clash between the disruptive Silicon Valley mentality of we're going to go change healthcare and we don't need to play by the rules with the traditional incumbents and stakeholders that are tasked with maintaining safety and quality in healthcare. And for a period of a few days, perhaps, it was unclear, what the path forward was going to be. And to her credit, Anne really rallied the company around taking the product through the FDA and figuring out a path forward and investing in doing it the right way. And that was a really hard process. If anyone has ever built a quality system, you know how painful it can be to build software under those circumstances. But we built and implemented a quality system and did a number of submissions to the FDA and a bunch of meetings. On the product side, we actually had to redesign all of our health reports and then demonstrate 90% comprehension of key concepts in a representative US population at an 8th grade reading level. So essentially, we had to help 8th graders get an A in genetics. And so we went through iterative testing of qualitative and quantitative testing on tens of thousands of people to demonstrate we could do that. And ultimately, that was a key part of the approval there. But my takeaway and my real learning there was, as much as I loved consumer-driven digital health and the opportunity to empower consumers and disrupt healthcare, I believed after that experience that the real way to do it was not from the outside in, like 23andMe was doing, but from the inside out. And to be a healthcare company that is consumer friendly and uses technology to solve new problems, not a technology company trying to do healthcare. And so I started looking for my next thing that was going to be that. And I was excited to find a small startup called Lantern, founded by a guy named Alejandro Fong, who's one of the best guys in digital health.
Yes.
And really great team there doing digital cognitive behavioral therapy with coaches. And so another example of a company being a little bit early in a market and suffering for it. But what was really cool about Lantern is they had gotten an investment from UPMC Enterprises, so the venture arm of University of Pittsburgh Medical Center. And having a healthcare stakeholder invested in helping to prove out the way to actually deliver these tools in a real healthcare environment was, I thought, a great opportunity, and brought together that idea of consumerism with real healthcare. And so joined that team, and we were doing some interesting work in the primary care clinics at UPMC, trying to make this app and experience prescribable essentially by their PCPs. But when we looked at the PCP workflow and workload and talked to the PCPs, we and I realized that the problem was much bigger, that the solution that I think we were looking at there was really a drop in the bucket relative to the need, and so it was sort of skirting a number of systemic problems and challenges that were present there. And this is one of the best resourced and highest quality health systems in the US. And the PCPs told us that they were overwhelmed by the demand for mental health services and support, that they didn't feel like they were in the best position to necessarily treat those patients, but that they couldn't get anybody in with psychiatry, and that it was a 12-week wait for the next therapy appointment. And so what that did and what that does is it made those PCPs essentially the mental health care of last resort for those patients. And rather than send them on their way, those PCPs were doing their best to treat those people and help them. But that fundamental mismatch, seeing that those PCPs were really guessing and checking when they were prescribing, that they couldn't really measure any outcomes with those patients or monitor their care or be responsive to their needs, that they didn't have much training for how to handle mental health well, really didn't sit well with me. And the main reason is that my father has managed depression my whole life. And I saw the ups and downs that he's gone through. When he first sought care, it took him over 10 years to finally find a treatment that worked for him. And, fortunately, he's doing well today, and that really changed his life. But I thought about this inherent mismatch and this systemic quality challenge where we've put mental health care in the primary care setting largely, and how many tens of millions of people are affected by that and struggling with that and not getting diagnosed correctly, not getting the care they need, not getting the outcomes they need. And I just couldn't live with it. I couldn't accept it. And I kept thinking about it and was determined to find a better way. And that was really the genesis of Brightside.
I love it. And some of these problems still persist, but you're able to solve them. So one of the problems that I see all the time is just the long wait for mental health treatment nationwide. there's not a city where there's an abundance of mental health specialists ready. And as you said, that's why PCPs tend to kind of take on these cases. But
That's
how
right.
are you taking the fixed number of mental health professionals we have today and making them more efficient so that there's not a wait time so people can get care faster?
Yeah, that's a big question with a lot of facets, and I imagine we'll touch on it in a few ways. But you're right that one of the biggest challenges, and the reason that that situation exists at UPMC and pretty much every health system in the US, is that we have a shortage of psychiatrists in particular. But in many ways, we end up with a shortage of therapists too, because this squeeze in the mental health care delivery market has made it so that a lot of practitioners end up not accepting insurance, and they go out because they can make better money in a cash pay market, and there's sufficient demand for them to do so. So a substantial portion of psychiatrists and therapists end up sort of going out of network, and if you're looking for in network care, essentially are just out of the market, and that exacerbates this shortage of providers. And one of the things that we do is, we're committed to being an in-network solution, to working with people's benefit so that healthcare remains affordable. In order to do that, we've built a platform and a set of tools and experiences, both for consumers, but also for providers, where we really treat our providers like customers, where we make it really easy and rewarding to practice on Brightside, and we help them earn really at market rates. And so in doing that, we can be more efficient in our care delivery, and we can take away a lot of the headaches that are additional reasons driving provider burnout and dissatisfaction in the US. So we make it so our providers have to do almost no administrative work. We make it so they have to do zero billing work.
That's like a dream come true.
Yeah,
Yeah.
yeah, exactly. And so that's really credit to my co-founder, Mimi Winsberg, who's our chief medical officer. From the first time we met, she said, we have to treat our providers like customers. Our providers in the US are burnt out, they're overwhelmed, they're overlooked. And so that was core to our product strategy, was really investing in tools that would make it easy and enjoyable for them to practice. We also, in addition to that and helping them really use their intellectual brain and really engage in care and connect with patients, we want them to see the impact they're having. I think that's the reason most providers got into being providers, is they care. And so creating a feedback loop where they can see the impact, where they can have real relationships with patients, as well as a collegial connection with each other. And I think, unfortunately, in telemedicine, a lot of systems are sort of treating providers like cogs in a wheel, right? You've got you can rent a network and add a provider here or there, or you've got pools of providers that are just sort of waiting to address a need that might come up. And I think when providers feel like cogs in a wheel are just interchangeable, there's not a lot of work satisfaction there. It's sort of piecework. And so we think of it very differently. We think the right thing to do clinically is to have a one-to-one patient-provider relationship from start to finish, but also that's what providers want and value and feel satisfaction from.
We'll be right back after the break.
Has your chronic illness made it difficult to continue working in the traditional way? Want to learn how to find and create flexible remote work that both accommodates your chronic illness and generates an income? Join the Patients Getting Paid membership, a community of chronicpreneurs where people just like you find workshops and trainings, weekly updated condition-specific gigs, twice monthly coaching calls, co-workings, accountability, and the kindest community to support you on your path to make money while working from anywhere and taking good care of yourself. Learn more or join us at patientsgettingpaid.com.
So you guys you're moving virtual care up the clinical spectrum, and will soon be even treating people who are the most vulnerable through a crisis care program. And that is intended for people who are actively suicidal. Can you tell us more about this program and what led you to I don't think anybody else is focusing on this group specifically.
Yeah, and that's exactly why we are, because it's a big need and a big opportunity. From the start, we took the care we're delivering very seriously. We weren't in a hurry necessarily to get to market. we were committed to doing it right. And my two co-founders each lost a parent to suicide. And as I mentioned, my father has struggled with depression.
Wow.
And so when we sat down and said, what kind of company do we want to build? We essentially said our quality bar is that we'll only deliver the quality of care we wanted our family members to have when they needed it. And that set the bar very high. It also caused us to focus on the higher end of complexity and severity and acuity rather than wellness and self-care and where we see a lot of digital health tools that are necessary and important tools, but are very different from what we do. And so from the start, we saw in our member population that people had very high severity and very high needs. So about 4 out of 5 of our members start with severe or moderately severe depression or anxiety. About half start with suicidal ideation. So we
Oh, wow.
have always treated sort of adjacent to the population of sort of suicide crisis. When you think about suicidal ideation, you can sort of bifurcate it. You can ask people when they have SI, is this a vague thought or feeling, which is very common, or are you making tangible plans to actually think about this? So in the former, we've been treating those people for a long time, and we actually just next week are going to be publishing a paper in JMIR showing our outcomes specifically among the population that present with suicidal ideation, and just really phenomenal outcomes of reducing and eliminating that SI. In the cases where people were actively planning for suicide, obviously that's a very high risk situation, and those people need timely and attentive care. And so our stance was, we don't want to deliver any care that we're not confident can be safe and effective. Let's refer those people for in-person care. And I was at a conference a little over a year ago, and I met an executive from one of the national suicide nonprofits. And she was asking me about our position in there and how we can help people with suicide risk. And I told her that, and she said, I really encourage you to revisit that thinking, because when you refer those people for in-person care, we know how hard it is for people to find mental health care. There are weeks and weeks of wait. And there's only a subset of mental health care providers that are comfortable treating people with suicide risk. So a lot of these patients become a hot potato. They call and try to get appointments, and no one wants to take them. And so the people who need it the most, they need timely, effective care, aren't getting it. And those people end up in the ER, or they end up in inpatient, and they end up killing themselves sometimes. And so I asked Mimi to take another look at it to say, can we, if we developed the right program and the right tools, safely and effectively deliver crisis care to support people with active suicide risk? And with the support of this executive, she found a program that she felt was really great, had a bunch of research behind it that we could productize and deliver on our platform, and be able to support patients who are in this situation. And so, we've been building it. We're really proud of that work and of our opportunity to help the people most in need. And we'll actually be launching that in the next 2 weeks in a couple of states and roll it out nationally by the end of the year. So huge opportunity to impact patients. As you mentioned, no one in the market is doing this. I think we'll be the first and only national provider of crisis care services. And the real opportunity from a commercial standpoint is to partner with all the healthcare stakeholders who are already touching these people and trying to help them find care. So payers and providers and employers, and really help reduce ED visits and inpatient stays and negative outcomes that are really costly and in many cases ineffective.
Yeah. So you're helping them not kind of fall through the cracks when usually a provider might pass this along to in-person crisis care. You're going to be delivering this virtually, and hopefully there'll be some great data that you learn, because this seems a lot scalable. If there is a lack of, experts in this area and patients end up bouncing around, it seems like a virtual option could make sense here.
Absolutely.
Yeah.
And, with the advent of the 988 crisis line, we're going from a large volume of calls to a massive volume of calls and people seeking crisis support. I can't remember the stats off the top of my head. I'm sorry, but nearly 50,000 people a year commit suicide in the U.S. For every person who commits suicide, there are something like 27 who attempt suicide. So there are nearly 1.5 million suicide attempts a year. And then for everyone who attempts suicide, there are a number 200 plus who seriously consider it. So we've got probably about 15 million people a year in the U.S. seriously considering suicide and being at risk and sort of in this dangerous escalating situation. And so there's a major need, there's a major gap, and it's a space we intend to fill and deliver real help in a scalable way.
Yeah. And I've heard that some folks are hesitant to call the suicide hotline because they believe that they will just call the police and get law enforcement involved. And there are populations that their life would be at risk if a police officer got involved.
That's right. That's right. Yeah, it's a tough problem. So, we don't intend to be a replacement for a crisis line, right? So you might still call a crisis line and need in the moment support to de-escalate. But what we would be is you could get a referral from a crisis line to Brightside or from a provider to Brightside, or so that you can go from that moment of de-escalating and reducing your risk into a sustainable plan to bring yourself down out of that crisis area.
Yep. So let's talk about how COVID changed the mental health landscape and increased the prevalence of anxiety, depression, isolation, suicide. How you started this business before COVID, you've gone now through almost 3 years of this pandemic. How have the needs of Americans changed in this time?
I think we all have experienced this ourselves, with our families, with our communities and friends, and seen lots and lots of news about it. So it's not going to be a surprise to anybody that COVID has exacerbated and accelerated a lot of feelings of loneliness, of anxiety and uncertainty, and associated depression. We also, have seen suicide rates go up. Certainly, this is worse in subpopulations. The youth and teen market in particular is an area where there's been a lot of challenge and really spiking rates of depression, anxiety, and suicide risk, and a lack of resources and insufficient care to support those people. When we started Brightside, we had a longstanding belief and thesis that mental health need in the U.S. was growing, and that remote care could be an effective way to support that. If you look, for example, at the suicide rate and the data that the CDC publishes, there was a kink in the curve back around the year 2000 or 2005, where suicide rates had been somewhat steady for a long time or growing very slowly, and then all of a sudden they started to grow more quickly. And from about 2000 to 2020, we had a 30 to 40% increase in suicide rates, and sort of more in subpopulations than others. And so this trend was already happening. There are a number of forces at work in our society and in our culture and modern life that are driving increased rates of people wanting to kill themselves. And so that was already happening. We already had a crisis, and COVID really accelerated and accentuated that. It made it faster and stronger and worse for lots and lots of people. And so it's been a real challenge and a real tragedy. Of course, it's been a positive thing for the telemedicine market. It's been a period where people quickly became aware of and tried and adopted remote care, and found that remote care was not only a viable option, but in many cases a desirable option. And so that might be the silver lining, that it sort of helped people find better help faster.
And providers got more comfortable using these tools.
That's right. And so it's setting us up to do better going forward, I think, with more solutions to try to address that problem. But we have a major, major problem on our hands, and we need all the help we can to try to solve it.
Yeah. What do you think are some of the biggest barriers to innovation in this space?
There are a number of things that are barriers in healthcare, and I think we could talk a long time there.
Specifically in mental health care.
Yeah, in mental health, for me, the biggest barrier, the sort of meta barrier that I see, is that for many, many years, we have conceived of and treated depression as one thing. We've thought of it as sort of a one-dimensional condition that has a few treatments, and we can just sort of throw those treatments at it and we'll see how it goes. Ultimately, that mental model, we believe, is just wrong and sort of complacent, short-sighted thinking. The reality is that depression is extremely heterogeneous. You have, the diagnostic criteria for depression are, you've got to have one of two core symptoms and 5 of 9 total symptoms on the DSM-5. And of course, it's not very hard to critique the DSM-5 and some of the way some of these things are measured, but they're the best things we have today. But within those 9 symptoms, you can have thousands of permutations of different clusters of symptoms and different presentations. And people can have vastly different experiences of their depression. A couple examples are, there are 2 of the questions there that we call bivalent. So for example, one of the criteria or one of the symptoms might be sleep disturbance. But within that sleep disturbance, you could either have insomnia where you can't sleep or hypersomnia where you can barely get out of bed. You've got the absolute opposite experience, but you sort of check the box of the same diagnostic criteria. So we're actually doing an analysis right now, and we'll be publishing soon an evaluation of all those different permutations and clusters. And we're talking, over 1,000 different ways that somebody can present, and especially if you overlay depression and anxiety together. And that's not even in considering sort of the severity of each one of those symptoms that are, if they're present, would be ranked on a scale of 1 to 3. And so that heterogeneity demands more personalized treatment to get it right for each individual, not just try to throw the same treatment or same medication at everybody and hope that it works. And ultimately, when people criticize the medication class of SSRIs and similar meds as saying that they don't have much effect over placebo, looking at the data from some of the early clinical trials, I think that's true. That's a fair conclusion, and smart people have looked at it and made that conclusion. But the challenge that I believe we have there is that the trials were designed with this idea of sort of depression as one thing in mind, where the inclusion criteria were just, do you have depression or not, and a couple of other things. They didn't account for this inherent heterogeneity. And what we believe is that if you take this into account, you can actually get much better effects out of this drug class, where if you can identify people who are likely to respond or unlikely to respond before you choose a medication for them, you take all the people out of your denominator who weren't going to respond, and you can actually see a much bigger effect size. When you've got everyone in the same bucket, you have a regression to the mean, and across the drug classes, you don't see as big of an effect size as you'd like to. But we're turning that sort of blunt instrument into a more precision approach and seeing much better outcomes. And it's a real mental frame shift for the healthcare industry. And even like physician references, like Up to Date, tend to still have information saying if someone qualifies for a depression if someone qualifies for a depression diagnosis, try an SSRI. And so there's just not much specific guidance or rigor around the idea of understanding and matching people to treatments and making sure to get it right for them. And so if I could change one thing about mental health care, it would really be this frame shift of helping all of us collectively think more deeply, understand more deeply, approach treatment with more rigor and thoughtfulness to get it right for each person. I think it's been driven in many ways by a feeling of helplessness. Like, mental health is so difficult and intractable, and it's extremely difficult, but there is the opportunity to turn it from art to science. And that process is starting, and we're going, but we need to bring a lot of people along with that thinking. And we're trying to change that. And that's my hope that we will.
Yeah. So currently, correct me if I'm wrong, but a physician will work with a patient and try various medications until they find something that works and kind of complement that with therapy. Is there room in the future for this to be somehow more personalized using genetics or other healthcare information that could help you get it right the first time?
Yeah. So if you look at that clinical trial data and at practice, so when a provider prescribes an SSRI to a patient in this guess and check model, usually they'll get it right on the first try, something in the area of 35% of the time. Using this precision medicine approach that we're using, where we take data in about every individual, we analyze it using our proprietary clinical decision support, and we make a treatment suggestion to the doctor at the time of prescribing for them to consider. Our providers are choosing the right medication over 70% of the time on the first time.
Oh, wow.
And we define the right medication by the patient ultimately, achieving remission on that medication.
Yeah.
And so there is the opportunity just with phenotypic data and more thoughtful personalization to do that. And there is absolutely potential to consider more data inputs to keep getting better and better at that. So we're really investing in machine learning and in our data team. So really proud to have Hans Nelson join our team as our SVP of data. He comes from GoodRx and just the phenomenal team over there, and bringing a lot of rigorous approaches to going deeper and deeper into our opportunity to really make smart recommendations and decisions. Of course, from my time at 23andMe, I'm really interested in genetic data. And there is real potential there. But the truth is, when you look at the clinical actionability of the pharmacogenomics tests for antidepressants today, it's very limited. So the cost and operational delay of doing a test and getting the result relative to the valuable information you provide to that prescriber doesn't yet provide a really clear value prop. And so there's more research, there's absolutely potential there. And, I'm very interested in that space, but it actually, I think we're doing much better with phenotypic data than you could with genetic data at the moment.
Yeah. I mean, you guys are getting close to the right diagnosis every time, or the right prescription every time, getting certainly closer than the status quo.
That's right. Yeah. So that's our goal, is that every person gets the right medication, the right dose, often the right combination of medications, because many people in this case, benefit from more than one med as part of their treatment regimen. And we're making, using data and a feedback loop and machine learning, we're making that a much more scientific process to get it right, to reduce the trial and error process, manage side effects, and maximize outcomes.
Yeah. So we can't talk about online prescribing in mental health without talking about some of the hazards of prescribing drugs online. And a lot of listeners are probably aware of the company Cerebral, which was a new kid on the block. I think they launched right around COVID, promising just quick access to mental health treatments online, specifically around ADHD. But they got in big trouble. So I'm wondering, from your perspective, kind of, you've been in the space for a while, seeing kind of players come and go. Where's a good place to kind of draw that line between what's safe to prescribe online and how we prescribe it online?
It's a big and important question that has a lot of aspects to it. For us, it all started again with our values and our commitment to building a real healthcare company delivering real and robust care. And we were very cognizant that is hard, that takes time, and that takes a long view and investment in systems and processes to really achieve that rigor and that quality bar. And in doing so requires a little bit of patience for growth. And that's at odds with a lot of tech companies and tech investing and mentalities that really push for scale, and that, where a lot of companies and founders have been rewarded for driving scale. And so it's not surprising to me that there were companies in the market that made different choices about sort of a risk tolerance. But when the pandemic hit, when the Ryan-Haidt Act was temporarily repealed for the public health emergency, and that's the act that prohibits the online prescribing of controlled substances, Mimi and I talked, and I said, what's your opinion about this? Is this safe to do remotely? And she thought about it, and she said, I just don't think it's clinically responsible. I don't think it's defensible to prescribe benzodiazepines or other controlled meds like stimulants remotely. There's just too much opportunity for abuse. It's too hard to make sure that we can do it safely and effectively. And so we chose not to do it. We just said, we're not going to take that risk. It's not worth it. Of course, there's a bunch of money to be made. These are powerful drugs, that also have like substantial street value, and there's a lot of opportunity there. And I want to be clear that ADHD is a real condition, and people really need treatment for ADHD, and they've got a lot of challenges getting that treatment. I've heard a lot of those stories from people I know, and so I empathize with that absolutely. Yeah. But the reality is that there were a few companies that were really chasing the growth and the profits and did not have the clinical grounding in terms of the safety or the quality or the mentality around the right clinical priorities there to keep that in check. And so, there were a couple companies in the space that have had a really fast growth rate because of that, but it's come back to bite them. The DEA and the DOJ are investigating. There's the real risk of substantial penalties for that. Sort of the loss of confidence of many of the healthcare stakeholders. So it's in process still. It's unclear what's going to happen to those companies. But to me, it just represents a real divergence of Brightside from those companies, where we are a healthcare company. We are working with healthcare stakeholders like payers and providers as part of the healthcare ecosystem and adhering to all the quality and safety standards of healthcare. And there are some companies that are going to continue to be consumer companies, and they may make some different choices. And so I think the DEA is doing their job, and they're doing a great job. And we need safety and quality checks. And as consumerism in healthcare really continues to emerge, the reality is people have never had to be that much of a healthcare consumer. And it's a new set of considerations and things to look for. And so we've got to be proactive as an industry to establish our own quality bar, but also the regulatory bodies I think are taking a close look at it, as are the payers. And so for us, it's actually a good opportunity because some payers who had contracts with some of those companies terminated those contracts and said, you're not in our network anymore. They also, because of that, did a full review of all of the contracts they have. And in having them look at our contract, it gives us an opportunity to go deeper and show them the data about the care we're delivering, the impact we're having, and the opportunity to go do it the right way together.
Having that discipline up front kind of gives you a longer, bigger opportunity.
That's
not
right.
trying to chase the short dollars. I mean, pill mills have been a problem and have been around for decades. That's not what's new. It's that they're tech enabled, and the scale at which they're impacting patient lives is much larger than a single physician in West Virginia, giving out too many pills to people that come in.
That's right. Yeah. It's at a much bigger scale. And,
yeah,
I think there's one other factor at play that affects it, is that the consumer market is a really challenging one. And I've got lots of mixed feelings about the consumer market. I love being able to reach consumers directly and engage people in their care. At the same time, there was so much venture money that came in, a lot of companies that got funded and were chasing the same consumers with their marketing dollars that really drove up marketing costs to acquire consumers, and also caused certain companies in the market to do a lot of discounting. And so what happens, though, when companies are really trying to compete on cost is that they've got to maintain some margin on the back end. And the only way to keep any kind of profit margin is to try to ration their clinical costs on the back end. And so the consumer dynamics there create a little bit of a race to the bottom, where you got to try to get your price low to attract consumers, but then you can't spend too much on your clinical care to support them. And I think that's part of the cycle too, where it's dangerous to be prescribing particularly controlled meds in a clinical delivery model that's just not matched to the needs of those considerations.
Mm-hmm. So last question for you as we wrap up. If you could wave a wand and change anything in healthcare, what would it be?
I'm gonna tell you a few things there because you can't just do one when you start going down this path.
Okay, so your wand is that you get 5 wishes.
Okay, so my first one within healthcare, I wish that everybody with a chronic health condition would get mental health support. I think it's just, so many Americans are managing chronic health conditions. It's clear that mental health care, or that, mental health is a big component of that. It's hard to manage those conditions, and it comes with a lot of associated challenges and feelings and difficulties. And that drives a lot of cost. It drives worse clinical outcomes. And we know that mental health support can help manage and mitigate that. But only a fraction of people with those needs end up actually getting mental health care. So that would be a big wand I would wave. Mm-hmm. Second, I would change Medicaid mental health service rates. The Medicaid population is arguably the population most in need of good mental health care. And the rates that are paid for mental health services within Medicaid are unfortunately just not financially sustainable for a mental health care delivery company. You'll lose money on every encounter, basically. And so it really is preventing a lot of companies from being able to effectively serve that market. Now, there are risk pools and ways, if you're creative about taking on risk, that you can get to part of it. But we're really at, I think, a challenging impasse there, where there's a population that needs help. And I think companies like Brightside and others who want to help, but it's a squeeze there. And I think we need some real thinking and change and investment. Next, I would break free of the paradigm that payers are in and have been in for a long time, that reimbursement and value is quantified in clinician minutes, right? Most billing codes in an outpatient setting are just quantified in terms of how many minutes a clinician spent, and you determine the code. That has blocked, for the time being, the ability for most payers to pay for asynchronous care, for software driven care like digital cognitive behavioral therapy, for coach driven care where paraclinicians may be effective and particularly if supervised by a clinician with certain populations. And so it has further exacerbated the clinician shortage and the opportunity to scale effective mental health interventions. We need the payers to break out of that paradigm and to embrace asynchronous solutions. Of course, they have reasonable hesitations about waste, fraud, and abuse and that kind of thing. And so, there's a path there. So those are my healthcare ones. Yeah. For not healthcare, though, the one thing I would change is we all need to put down our phones. And I'm guilty of this too. It's something I'm working on right now. One of the main things driving this increase in loneliness, in anxiety and depression is that we're all spending so much time on our phones. If you actually look at that suicide curve that the CDC puts out, some of the strongest hypotheses of what's caused that rate of suicide to increase is the growth of use of social media and technology. It's not clear what else might have been occurring at that time that would have this sort of long-term and sustained trend. And while in the moment, it's always tempting to look at our phones and it provides this moment of comfort and relief or perhaps dopamine release, what it's doing is it's getting between us and connecting as people and being together, being present. It's also fueling, I think, a stress cycle, right? Where if I check my email or my Slack, it might take away the stress in the moment of wondering what was on there, but then it just gets me starting to think about work again when I might have been present with my kids or my family or myself and just in a more calm state. And so I'm really working hard on this, and it's hard. And I think we all need to take it very seriously. I don't think it's just a trivial lifestyle thing. I think this is a major trend and epidemic, really eroding our connection and happiness. Yeah. And I think we, as a culture and as a society, need to find that balance and need to be very intentional about it.
Yeah. And we didn't have social media as kids, but kids today, I mean, I can't imagine how their brains are forming around these ideas that they're getting of a picture perfect life and reinforcing. It's just such a loose tie to reality when you're on social media.
That's right. I've got 3 little kids, and I am really worried about it. I don't have the answers yet of how to manage that with them as they grow up. And
I know I have a 5-year-old who recently told us he wants to start making YouTube videos because he likes to watch the YouTube, the brick builders on YouTube doing Legos. And so now he wants to do them. Like, oh my gosh, no, I can't have an influencer as a child.
Well, I don't know. His mom is a media star, so you might want to follow.
Oh, goodness. Well, this was a great conversation. Thank you so much for all your time and insights. It's so cool to hear what you're up to. And I'm really proud to be a little part of Brightside.
Well, thank you. It's always good to talk to you. I really appreciate all the great work you do trying to help people understand this market, this potential, and all the great people and companies that are working hard to change the way healthcare is delivered and impact lives. So thanks for your support and all you're doing.
Yeah, we're doing it. All right. Thanks, Brad.
Thanks for listening to this episode of The Heart of Healthcare. If you like the show, be sure to subscribe, leave a review on Apple Podcasts, follow us on social, and tell all your friends to listen. The Heart of Healthcare is a product of OffScrip Health. We are a healthcare engagement company built for patients and caregivers by patients and caregivers. Our executive producers are Matthew Zachary and Andrew McDowell. Our senior producer is Brianna Seeley. Our host is Hallie Tecco. It is recorded, mixed, and edited by Brianna Seeley. For advertising and media inquiries, email media@offscrip.com. That's media@offscrip.com. For more information, visit offscrip.com.